Great. Okay, well, hello everyone. And we have more folks joining. This is great. Thank you so much for joining our session for today. We're just going to wait one more minute because people are trickling in. I don't want people to miss our beginning talks. Okay. So thank you again, everyone, for joining us today for this really important topic on life after kidney transplant. Today, we do have one of our really amazing and just amazing guest speakers with us who's been with us last year as well. And we're always happy to have him come back, Dr. Matthew Weir. He is with London Health Sciences Hospital. He is in the Department of Medicine and Associate Professor of Endomology and Biostatistics at the Schulich School of Medicine and Dentistry. So he's joining us today, and he'll tell a little bit more about himself and his hobbies, what he likes, what he dislikes, a little personal self himself. But we're very happy to have you here. Now, just a little disclaimer, please be mindful that for this session today, these are general questions that Dr. Weir is answering with general answers. So if you have any specific medical questions, please go back to your own medical team. He's not unfortunately able to answer anything specific for your own health journey, but please take what he says with regard to your own team. And then if you do have any questions, we do have a Q&A at the very top of your screen or the bottom of your screen. So if you do have a question, you can put it in the Q&A icon, or you can wait until the very end of his talk, and then we can address questions live as well. So you can do either format, whichever one works best for you. But again, please be mindful, we can't answer direct questions towards your own medical kidney journey. And with that, I'm going to pass it on to Dr. Weir.
Thanks very much. Can you hear me okay?
Yep.
Good. So yeah, I just wanted to reiterate that not only is it probably not appropriate for me to answer specific health questions, but it's also just not accurate. I've given a lot of answers for this talk that are just targeted at the average, and there are people on either end of the average that these answers won't apply to. So your own situation is probably best addressed by your own doctor, but I'm going to do my best to try to answer some of the questions that people had. Riz and I were talking about this when we were planning it, and I was trying to think up things that I thought people wanted to know about transplant, and in the end, we both had the realization that it's probably better to ask people what they want to know about transplant, and then I would answer the questions rather than me just guessing what I thought was important. So we got a lot of questions submitted, and what I've done is I've grouped them together into topics, and then I also tried to put some of the longer discussions at the end, just in case we didn't get through everything. So I want to try to get through as much stuff as possible, and then some of the more kind of complicated discussions I save for the end. That way, if we have extra time, we can use it for that. So. So the first set of questions I got were generally about longevity. There were a number of questions about stages of CKD and how things go at certain stages, and more about like how the transition is between different stages. Specifically, there was a question about how long could you stay at stage 4 CKD before you reach stage 5, which is generally the range at which you're closest to needing dialysis. And the answer is, and this might sound like a bit of a cop-out, but the answer is that there's no real defined answer I can give. Everybody's journey is different. Even people with the same condition, even two people with diabetic kidney disease might progress differently. The best way to the best way to figure this out is talk to your nephrologist, and if there's enough data. What I do for my patients sometimes, if they're progressing at an abnormal rate, is I'll look at how much GFR, which is the measure of kidney function that we use, how much GFR they're losing per year, and then from that you can kind of extrapolate when someone's going to reach a more critical stage of CKD. So and the stages don't really matter that much because nothing really happens at transitions between stages. So we use changes in EGFR as a marker, and we also use something called the kidney failure risk equation. And this is an equation that your nephrologist can use to help predict your risk of needing dialysis. And that's more meaningful because it's based on more current data, and it's also there are signposts along the way where at certain risk levels we start the education process of the dialysis, and at other risk levels we start the process of choosing a modality for dialysis and getting access created for dialysis. So it's a more clinically relevant measure than I think the stages of CKD are. There are a number of questions about how long you can live on dialysis. And that is a very personal question because a lot of your own other medical conditions go into it. The very broad answer that you'll see, and just this is an important. It's a hard question, but it's an important question. When I typed in how long can you live into Google, the fourth most common question was on dialysis. So this is something that a lot of people are wondering about. How long you can live on dialysis relates probably a lot to your comorbidities, which means the other conditions that you have. Some people who asked this question in the questions told me that they had hardening of the arteries in the heart and valvular problems in the heart. And certainly those things will affect your lifespan to a significant degree. Somebody who maybe just has something like polycystic kidney disease and doesn't have a lot of other medical problems and starts dialysis at a young age can live on dialysis for decades. Somebody who is already older by the time they start dialysis, who has a number of comorbidities, things like diabetes, heart disease, COPD, smoking, people who have dementia will live a lot shorter. The average answer that gets reported a lot is the 5-year survival rate is about 50%. And that means if you have 100 people who start dialysis, 5 years later, on average, is when there will only be 50 left. That's having an average number like that for such a broad range of survival rates is a bit misleading. So it's really it's down to your specific characteristics. There are risk prediction tools that your nephrologist can use to guess at your survival rate on dialysis, if that's something that you're really interested in. If you're using it to weigh whether or not you should pursue transplant, there's something called the estimated post-transplant survival, which is a number they use in the United States to allocate kidneys to people based on how long they're expected to live with it. And that's something that your nephrologist can do for you. There were a number of questions about how transplant generally goes for people who are older. As you get older, your age probably matters less and less for your health compared to younger people. Younger people are all kind of the same, but as you age, somebody who is a healthy 70-year-old might have a better chance of getting through transplant than someone who's 60 who has a lot of other medical problems. So for that reason, we don't evaluate, we don't exclude people from transplant just based on age. We evaluate people's overall health. So transplant can go very well for older people. I would say, though, in general, it is a little bit harder to go through. I mean, I don't bounce back from injuries as easily as my kids do. And as you get older, your ability to get through trauma, especially major surgery like transplant is harder. People who are older tend to spend a little bit more time in hospital afterwards following a transplant and maybe have a few more complications on average. But the assessment process before transplant is rigorous. And so if your team thinks that you meet the criteria for transplantation, then it's probably worth pursuing if that's what you're interested in. There were a number, and this is a very important question. There are questions about how you maximize the length of the graft. And graft here, I'm talking about the transplanted kidney. So how you maximize the life of the transplanted kidney. There are two kind of broad areas that go into this. One is what everyone kind of worries about, which is rejection of the kidney. And there's a lot of things like, random rejection episodes or infections that that you don't really have a lot of control over. But what you do have control over is how regularly you take your medications. The anti-rejection medications are very important for the life of the graft, and it's important to take them regularly. And I say that not just meaning you need to take them every day, but what we do with one of the most important transplant medications is we measure levels of that drug. And so it's important that you take it at the same time every day, and that time is coordinated approximately with the time that we would tend to do blood work. So for example, in our clinic, patients will do blood work sometime between 7 and 9 a.m. in the morning. And what we're looking for on that blood work is we're looking for something called the trough level of their drug, which just means the lowest level that drug will reach in their body in that 24-hour span. And that lowest level is usually right before you take the next level, the next dose. So if you're going to have your blood work drawn at 8 in the morning at clinic to measure your level, it's a good idea to get in the habit of taking your pill at 8 in the morning so that we get proper trough levels. That allows us to aim your drugs at the appropriate levels, not to get too high, not to get too low, and open the door for rejection. The other thing that I think that's important with the life of the graft that people don't always appreciate is that after you have a transplant, people have the same risk factors that the general population has for mortality. And the biggest killer of people out there right now is cardiovascular disease, and that holds true for our kidney transplant patients as well. So prolonging the life of the graft is about taking care of the graft, but also taking care of yourself. Blood pressure control, diabetes control, taking your cholesterol medications, exercising, and eating a healthy diet are all important things for your cardiovascular health, and that also supports the life of the graft. There was a specific question about is there anything special for a kidney pancreas combined graft? And no, I spoke. Our transplant team is only peripherally involved in what we call a KP or kidney pancreas transplant. But I spoke to some other team members who do that area specifically, and there's nothing different than what I told you for maximizing the life of a regular kidney graft. There were a lot of very good questions about post-transplant care. And a lot of people kind of just want to know what post-transplant care was like. So I thought I'd break it down. And there were questions on all these different stages, so I thought I'd kind of break it down. The hospital length of stay is different across North America, and it's even a little bit different in Ontario, just depending on on what type of ambulatory care services are available in your area. Here in London, the length of stay is on average about 6 to 7 days. And that is usually down to the amount of time that you have to have a Foley catheter in your bladder to protect the kidney as it heals. That usually has to be in for 5 days. And so by the time the Foley catheter is removed from the bladder after 5 days, and by the time we get a chance to get the drug levels right, it's usually about 5 to 7 days or 6 to 7 days in that ballpark. Certainly if there's complications, if there's early rejection episodes or infections or problems with the blood flow in the graft, those lengths of stays can go a lot longer. After you have a transplant and you're discharged home, people want to know what the clinic schedule is like. Once again, there's a lot of variability here. There are some places that do a lot more remote monitoring. There are places that bring people into clinic a lot more frequently. But in general, I think it's safe to say that most places, the care is very intense in the first month or two, and then things spread out a little bit. Here, we would see people either once or twice a week for the first month, and then we would lower the frequency of clinic visits. down to about once a month, maybe for the first 4 to 6 months. And then after that, quarterly, so maybe every 3 or 4 months, depending on how things are going. It's certainly, if there are complications like infections and rejection, those post-discharge clinic visits can be more frequent, and we have some people who we see once a week going on for 2 months. But that's an outlier. The average, once or twice a week for the first month, and then stretching out from there. People who have had a transplant for a long time, we would just do blood work once a year and see them once a year. So people have had transplants for more than 4 years. They would only be interacting with us twice a year. There are other places, I know Hamilton, I think, does blood work every 3 months forever. And then they see them in person once a year for those longer lasting transplants. There were a lot of questions about medications, and I think I come back to medication side effects at another slide. The medications that you need after transplant, most places use a triple drug regimen. The first drug is something called a calcineurin inhibitor. The most common one is tacrolimus. That's the one there where we measure the levels very carefully, and that's the one that needs to be taken regularly at a certain time of day. We also use an antimetabolite, either something called mycophenolate mofetil or mycophenolic acid, and that's a medication that's taken twice a day. And then most people are on prednisone as well. Prednisone is a steroid. It has a lot of side effects that people don't like. We start at a very high dose and then lower it over the course of the transplant. Similarly, the levels that we try to achieve with tacrolimus are high at first, and they decrease over the life of the transplant. Our program lowers the tacrolimus targets at 3 months, at 6 months, and then at 1 year, depending on how things are going. There are certainly exceptions to these rules. There are some options for people to be on a steroid-free or a prednisone-free regimen. There are risks associated with that, of course. And there are alternative medications to tacrolimus. The commonest one that we would use is a drug called sirolimus, and we use that in some people who cannot tolerate tacrolimus for a variety of reasons. There are a lot of questions about some of the good things that people can expect after transplant. And then the number one was, are there medications that you can stop once you get a transplant? So yes, there are medications that we put you on because of the transplant, but then on the flip side, there are medications that are often stopped. Medications that are there to support the red blood cells, like the injections of either Aranesp or EPO, are often stopped. The transplant kidney usually does a better job at getting rid of fluid and salt from your body than dialysis does. So in a lot of cases, we can either stop or reduce the dose of diuretics and blood pressure medications. A lot of people still need blood pressure medications after transplant, but I would say on average, the number of meds that people need for that are lower. Medications you take to bind phosphate in your diet when you're on dialysis are generally stopped as well. Of course, there's exceptions to these rules, but generally those are stopped. People who are feeling dialysis-related symptoms, if they are truly related to dialysis, they tend to go away with transplant. If your appetite is poor or you have itchy skin, there's lots of reasons you can have that. If it is truly related to dialysis, then transplant does fix those things. But some people who have itchy skin on dialysis and attribute to dialysis, once they have a transplant and the itchy skin is still there, then we have to pursue an alternative diagnosis for their itchy skin. A common question was when you can travel and when. That's a common question in the questions that were submitted. That's also a very common question in clinic, and that's totally understandable. Dialysis tends to keep you stuck in one place, and people are itching to travel, and that's totally understandable. We recommend not traveling for the first year. That's just because that's when the complications happen. That's when the infections happen. That's when there's lots and lots of clinic visits. That's when we might have to do a biopsy. and traveling does get in the way of that. So it gets in the way of our care in the first year, but also you run the risk of running into problems when you're traveling. So traveling in Canada is certainly a lot safer than traveling overseas or in the United States. There's risks of getting sick when you're overseas or in the United States, both to your health if you can't access proper medical care, and also to your bank account if you end up getting medical care and it ends up costing you a lot of money. So we usually recommend that people wait a year before they travel. Um, there are interesting questions about what happens to your original kidneys that we tend to call. So we'll call the transplant kidney the graft, and we call your own kidneys native kidneys. So there are some questions about what happens to your native kidneys. As some people may or may not know on the talk, the new kidney or the graft is put in your pelvis, which is kind of like right underneath where you'd wear a belt. And this is done because it's close to the blood vessels that we hook the kidney into. It's a easily accessible area for the surgeons. And the connection from the kidney to the bladder, which is called the ureter, tends to be a little bit shorter in transplants when they get the kidney. So it's a way of getting the kidney closer to the bladder and keeping that ureter connection easy for the surgeon. Oh, easier. I don't want to say it. If there's any surgeons watching this, I'm sorry. Your job is not easy, but it does make it a bit easier to connect the ureter to the bladder when it's close and in the pelvis. So we put the kidney, the new kidney, in the pelvis, and the old kidneys we just leave. Unless there's a very strong reason to take them out. Often the original kidneys still do provide some fluid clearance, and so there's no point getting rid of that. Getting your kidneys out is a relatively big surgery, so having that unnecessarily is not a good idea. Kidneys do get removed in people with polycystic kidney disease whose kidneys are very large. So one of the questions I think the person who asked the question might have polycystic kidney disease because they talked about their abdomen being swollen. And so yes, if your native kidneys are polycystic and very large and causing mechanical problems, like early satiety, like having trouble eating or pain in your belly, then those kidneys do come out. Occasionally, kidneys that have a chronic infection are taken out so that they don't cause problems with the transplant and the anti-rejection medications. But for the most part, your native kidneys are left in. Understandably, people asked about complications that arise. There are some questions about recurrent disease, if a disease would come back. And there's a wide range of things that happen with your original kidney problem. And I put some examples here. So diabetes is a very common cause of kidney failure, and diabetes does start to affect the graft. The nice thing, though, about diabetes is if it's under control and well managed, even though it's affecting the graft, it doesn't cause a lot of damage fast enough to really limit the lifespan of the graft. There's other conditions like polycystic kidney disease that just do not come back. This is a genetic condition that is a part of your native kidneys, and it's not a part of an organ that we would transplant into people. Donors are screened for that type of thing, and we endeavor not to transplant polycystic kidneys into people. And to my knowledge, I'm sure it's happened at some point in the history of time, but I can't think of a case where that has happened. But polycystic kidney disease does not come back in the graft. There's other conditions, though, like IgA nephropathy, which is another common cause of kidney disease, that does come back. It tends to come back in a way that's similar to the initial presentation of the kidney disease. So if you had IgA nephropathy and it wiped out your kidney function very quickly, there's a higher risk that might happen again in the graft. That being said, with some of the immune suppressing medications you're on for the transplant, we tend not to see very early graft failure from IgA. There's a number of other kind of more rare conditions that can come back very quickly, but we do our best to deal with that. Weight gain is a common problem after transplant. So first of all, I acknowledge that prednisone does increase your appetite, and prednisone does put you at risk for weight gain. But the other thing too is that dialysis is not good for you, and people don't feel well on dialysis. And even people who feel relatively well, when they get a transplant, their appetite often comes back. And so gaining weight in the setting of a renewed appetite from better health with the transplant and the added effect of prednisone can definitely cause weight gain. Some medication side effects to talk about. People ask about them in general, but I was just going to go through a few of them. So in order for your body to tolerate a kidney that wasn't yours originally, we have to suppress your immune system. Otherwise, the kidney will be rejected. And by suppressing your immune system, we also impair the immune system's ability to do the things that you want it to do, like fight infection. So in general, the common infections that you get will tend to last a little bit longer when you have a transplant and you're on medications. There's a risk of them being a bit more serious as well. We see more serious urinary tract infections in people with a transplant compared to those without. We use some medications to prevent infections. Everybody is on Septra to help prevent some rare and serious lung infections. But infection is a common issue. We usually advise people to, before transplant, if you would rest at home for a little while with a high fever to see if you got better. We would generally advise people who have a transplant to not sit around for too long at home hoping to get better. We want to hear about it, and if there's concerns, we usually start antibiotics a bit faster on people with a transplant than in people who don't have a transplant. Your immune system also kills cancer in your body. Mutations that lead to cancer are really common, but most of the time our immune system kills them off before they cause any problems. But when we suppress your immune system, you are at a higher risk of cancer. There's some cancers related to viruses like Epstein-Barr virus that can cause some lymphomas after transplant. But the commonest cancer we see is skin cancer. Some of the medications predispose us to skin cancer. And sometimes it causes us to have to change medications in order to get the skin cancers under control. Thankfully, the skin cancers we're talking about are not melanoma. It's usually squamous cell carcinoma and basal cell carcinoma. Both of those are easier to treat than melanoma. I don't mean to discount their importance though, but they are a little bit easier to treat than that. There are metabolic complications of the transplant drugs. They all, some of them increase your cholesterol, some of them increase your risk of getting diabetes. And that's not just the prednisone, the tacrolimus can increase the risk of diabetes as well. So we do see problems with blood pressure, diabetes, and cholesterol in people who have had a transplant. But those are things that we actively treat in clinic. Someone asked if the transplant medications cause kidney damage, and I think that person probably knows the answer, and they do cause kidney damage. Primarily, the tacrolimus, the calcineurin inhibitor, can cause scarring of the graft. Most of the time, this is not serious enough to cause big problems, but occasionally we do see people whose graft has failed after a number of years, and it might be related to the scar tissue that these medications cause. We would love to use a medication that does not cause scar tissue in the graft, but that doesn't exist at this time. This is a complication that we have to tolerate because of how effective these drugs are at suppressing the immune system and allowing transplants to last longer. Oh, rejection. Rejection happens. It is not, if you take your medications reliably, it can still happen sometimes. So I spend a lot of time in clinic reassuring patients that the rejection episode that they experienced is not their fault. A lot of people take it personally, and it's not. It just happens sometimes, even when people are taking the medications properly. The nice thing, though, about rejection is that it's not like you'd see on TV where it's like an all or none thing and the organ is cast out of your body. Rejection comes in a number of different grades. The majority of the time we see very low grade rejections that we can treat with a temporary increase in prednisone or sometimes some intravenous medications that we would give in hospital. So rejection is not something to be, it's something to be concerned about and to take seriously, but it's not something to be fearful of. We tend to, the only way to diagnose rejection is with a biopsy. We tend to have a low threshold to biopsy people because we want to identify rejection early. So my advice is if your kidney doctor is suggesting a biopsy to rule out rejection, even though it probably sounds scary, it's the right thing to do. It's a relatively safe procedure. It's quick. And in jumping on rejection early definitely helps the long-term outcome of the kidney. There were some dietary questions. Someone asked if there were no food restrictions, and that was after transplant. That's a bit broad. I don't want to go that far because you still have to follow a healthy diet and take care of yourself. But in terms of the food restrictions that you often see in people who are on dialysis, there is generally not a phosphate restriction. In fact, phosphate tends to run a little bit low after transplant, and we encourage people to eat more phosphate. If potassium restrictions can sometimes come up after transplant because some of the medications can increase your potassium levels, but usually we deal with that by using medications like hydrochlorothiazide that helps the new kidney waste potassium. So even though potassium restrictions can happen, they're relatively rare following transplant. But to say there's no food restrictions is, everyone's got food restrictions. Here's a complicated question. Someone wants to know if they had to drink 3 liters of water a day. And as a kidney doctor, I spend a lot of my time both in the transplant clinic and in my general clinic trying to convince people that they do not need to force feed themselves water every day. Some people who have been on dialysis a long time are very used to drinking maybe only half a liter of water a day. Those people who have no drive to drink and maybe their thirst is a little bit impaired, they might need to set out a plan for how much water they need to drink per day. I think the majority of people can just drink as their bodies tell them to. The reason I'm speaking slowly is because I know that the advice I just gave you there is going to differ from what a lot of people will say in the transplant clinic and your kidney clinic. If you want to keep people happy and drink 1.5 liters of water a day or something more reasonable, that's fine. If someone is asking you to tell you need to drink 3 liters of water a day, I might politely ask for the evidence behind that. I know there isn't any. And then the other challenge of drinking 3 liters of water a day is that it's hard. That's enough water to probably kill your appetite. And it's enough water if you're not eating that much to actually get your sodium levels down in your blood, and that can be a little bit dangerous. So I would say you do not have to drink 3 liters of water a day. It's a personal decision that you can discuss with your nephrologist, but that is in no way a rule that's required to have a healthy kidney transplant. There's a question about THC and CBD after transplant. There's two answers to this. First, yes, THC does interact with tacrolimus, which is one of the important transplant medications. They are both metabolized in the same pathways in the liver, and so they compete for that metabolism with each other. So there is some data showing that that tacrolimus levels and THC levels can be a little bit higher when they're taken together. The second part of the answer is that I could not find any data showing that ever made a clinically relevant result for anyone. So yes, there is a theoretical and demonstrable interaction between the two, but no, I have not seen any problems with people using THC and tacrolimus at the same time. Once again, this is it probably relates to the amount that you're planning on consuming, and it's a discussion that needs to happen with your kidney doctor.
Dr. Weir, just to really interrupt, can you explain THC and CBD? Someone had that question.
Oh, I'm sorry. THC is oh God, now so it's cannabis. The C is cannabinoid. I can't remember what the TH and the BD mean, but they are the two active parts of marijuana. THC has more of the kind of effects on your mind, and CBD is what people think has some of the pain relieving and maybe appetite stimulating effects. So that's basically. Sorry about that. I guess my defense is I don't know what those stand for, and that's why I didn't define them. But yeah, that is marijuana basically. Is that okay?
Okay. Perfect. Thank you so much.
All right. Exercise. Are there special precautions because the graft is placed in the pelvis? Yes, there are. There are. So the bending and lifting that's needed for a lot of exercise is tough on that surgical incision because of where it is. So what that leads to is us giving people precautions about when they can exercise. We generally say, so the skin heals pretty quickly. That's usually totally healed in like a week or two, but the deeper layers of healing take longer. So the general rule is about 6 to 8 weeks to avoid any heavy lifting or strenuous activity. One of our surgeons tends to tell people that by 6 weeks, he says, try jumping up and down. And if you don't feel any pain at that spot, then it's probably healed up as well as it needs to be. But once again, this is one of, like, to go back to the beginning of the presentation, this is one of those things that's quite variable. People heal at different rates. So this is something that requires a lot of individualization. But generally, 6 to 8 weeks is the limit. And exercises that cause a lot of that require a lot of bending and crunching are particularly difficult. This relates to the question about when people can swim. And yes, you can swim with a transplant, provided you could swim before you have the transplant. And when you can swim it's a bit nuanced. When you can wade in the water and not have the water affect the surgical incision is as soon as the skin is completely healed. And as I said, that can be like 1 to 2 weeks. So that's not a problem. But the problem with swimming is it's usually not just wading around in the water cautiously. It involves lifting yourself out of the pool, going up a ladder, going up steps, and that can be a bit more difficult on the surgical site. So when can you gently wade in water? As soon as the skin is healed. When can you actually properly swim and enjoy a backyard swimming pool? Probably same as the above, about 6 to 8 weeks. Cycling, once again, 6 to 8 weeks. It is a bit more difficult because you are pulling your legs up right in the area and kind of compressing where the graft would be, and you just want that surgical site to be completely healed. And as I said, both the skin and the deeper areas of that surgical incision. There's a few uncategorized questions. A few people gave me like very specific clinical scenarios, and I can't answer them because it's very specific to you. A couple of the questions were about some post-transplant symptoms that people were feeling. And for example, one was about fatigue. And I think if someone's asking, about their ongoing fatigue in this setting, it probably means they're not getting the answers that they want from their clinical team. And I understand that. So I understand the concern of the patient. from the kidney transplant team point of view, it's hard to deal with really broad symptoms like fatigue in the setting of the transplant clinic. When I started, we were doing about 60 transplants a year, and last year we did 152 transplants. So our clinic sizes are well beyond the capacity that our clinic space was built for. And that means to get everybody through clinic, we need to see 30 people in a morning sometimes. And I can't do the math, but I think that comes down to about 3 minutes a person. That's enough time to deal with the transplant drugs, the graft function, and some cardiovascular stuff. But to tackle big issues like fatigue, which is so broad, there isn't enough time. But that doesn't mean you just have to live with your fatigue. One thing I would recommend is maybe talking to your family doctor about those types of things. If your family doctor kind of kicks it back to your transplant team, then it might be worthwhile contacting someone and and maybe arranging to see them at a time that's not in the middle of transplant clinic, or emailing your symptoms so patients have done that with me, where I've had a chance to go over a lot of complicated issues outside of clinic time, and then by the time clinic comes up, I'm more prepared with a list of strategies. So that might be something that you can pursue to try to get some answers for some of the more complicated clinical scenarios. Someone asked why they can't know the details about their donor. I certainly understand wanting to know details about your donor, but from the perspective of the donor, donating a kidney, either as an anonymous donor or donating the kidney of a loved one who has just died, is a momentous part in people's lives, and they have to be completely in charge of how much information is made public about that. And people are in charge of that. The vast majority of people want to remain anonymous in this situation. And so we go out of our way to make sure that that is ensured. There were questions about knowing some like general details, like the age, the sex, the province of residence of the donor, and even though those present very small risks of identification of the donor, the risk isn't zero. So to take those small risks of identifying a donor when they don't want to be, you have to weigh it against the benefit of divulging donor information. And I don't think there's any benefit to divulging donor information. If you have a functioning kidney, it doesn't affect your healthcare or your management to know that kidney came from Alberta, or that the donor was a woman. These are details that are inconsequential for a recipient. And then the final part of that is if donors don't want to be identified, and a donor is accidentally identified, that could be very upsetting for them. And if they tell their friends that they tried to be anonymous, but someone tracked them down, that might discourage other people from donating who wanted to remain anonymous. And we're very protective of the people who make that huge gift to allow us to do transplant. And then someone wanted to know what I can tell them about xenotransplantation. And so I'm just checking my xenotransplantation is when you get a kidney or an organ from from something that's not human. Xenotransplantation started in the 1960s, and I think some people are surprised to hear that because that's a long time ago, and it's just in the news now. But in the 1960s, it started with non-human primates, and non-human primates share a lot of genetic material with humans. And transplantation was actually relatively successful, but there were a lot of challenges, both with the ethics of raising non-human primates for donation, and also some infection-related issues related to non-human primate infections that could be transmissible to the human population. So things kind of died down with xenotransplantation, but then have come back to the forefront now that the genetic technology exists to more efficiently edit the genome of other organisms. And so what's happening now is transplants that come from pigs. Pigs have a number of genetic and immune barriers that prevent them from being effective sources of organs for humans. But through genetic engineering, there have been a lot of changes made to these pig donors to make them more compatible with humans. The kidneys that were transplanted into a brain dead recipient to just see how they would do, I think had about 10 to 12 genetic edits made. The more recent kidney that was transplanted into a living human had, I think, 39 or 40 genetic edits done to allow that to happen. Still, that patient has required different immune suppression than the average person would get to try to compensate for some of the differences that still exist between pigs and humans as it relates to the immune system. So there's a lot of barriers to it right now. It's xenotransplant is not ready for prime time. There's a lot of people who are skeptical about it because it's been since the 1960s that people have been talking about it. So a lot of people are a bit blasé because they've heard about it and it's never materialized anything. But I think the current approach has got a lot more potential than it ever has before. So I don't want to sound naive, but I'm excited about this process. Not next year, but a number of years down the road, this might be something that provides an option to people. I think, yeah, and that's all. That's a summary of all the questions I think that were sent to me, and I'd be happy to try to answer some more questions if people had them.
And you have a lot, so let's go through one by one. All right. So the first question is, what would be the average healthy life after transplant if in relatively good health?
So probably the best way to answer that is like the expected survival of the graft, I think, is what. Yeah. So it depends. A kidney from a deceased donor is probably about 8 to 10 years, and a kidney from a living donor probably about 12 to 15 years. Obviously, those are guesses and averages, but that's about the range. Kidneys from deceased donors don't quite last as long because when the kidney is without blood flow for that long, there is a little bit of damage that happens that probably sets things back a bit. With a living donor, there's a very brief period of time that kidney is without blood flow, and so it bounces back a lot faster.
Okay. This one is about C. diff. If you could just mention that a little bit when it comes to transplant and infection.
C. diff doesn't have, to my knowledge, C. diff is not a particular concern with transplant. I mean, every infection is a little bit worse when you're on immune suppressing medications. So C. diff will be, C. difficile is a bowel infection that causes very bad diarrhea and is treated with oral vancomycin. Yeah, so it's not one of the special infections that we pay extra attention to in transplant. There's a list of those, but C. diff doesn't kind of pop up on my radar for that.
I'm now going to go to a little bit more of donor related questions that we have. So our first one is, do some or all of the possible medications apply to donors as well that recipients have?
Donors don't have to take any immune suppressing medications. Living donors go through a very extensive workup, and tend to be very healthy. We don't change any of their medications just because they donated.
Perfect. Next, we have, there's a lot of folks that are joining us from London that are post-transplant as well, and so they
Oh,
give
from
you a
London?
shout out.
Oh
Yeah,
God, they're
you
gonna
giving
hold
shout outs?
everything I say.
The Can prednisone ever be stopped? I know you mentioned a little bit about it, but stopped after transplant.
Yes, prednisone can be stopped, but there's a substantial increase in rejection. So we don't do it a lot because of the rejection risk. Some people absolutely cannot take prednisone, and we do have a prednisone withdrawal process. But it's just prednisone is a bad drug, but it's good at its job. And until we have a suitable replacement for it, we're for the most part we're stuck with it.
It's one of those love-hate medications.
It is. It's like that guy at work who nobody likes, but he's really good at his job, and you can't fire him. That's prednisone.
Yep. Okay. And every person's case is very different. So if one person doesn't mean that you should be doing it as well. You always have to talk to your medical team.
Oh yes, don't
Yeah.
change or stop any medications based on what I've told you today. Please talk to your team.
All right. Awesome. What if a person needs a third kidney transplant and their first and second grafts were transplanted in their pelvic area and their native kidneys are still present? Do you have to remove one of the grafts and replace it with a new one?
It's different for different people. We have patients who've had 4 transplants and none of them have been removed. Sometimes there's space issues that the surgeons figure out ahead of time, and they would plan to remove one of the kidneys if needed. But generally, they for the most part, there's enough room to fit more kidneys in.
Right. What are some of the symptoms of rejection that people should look out for?
If you read about symptoms of rejection, you'll read about, fevers, pain over the graft, kind of flu-like symptoms. I wish it was that easy. It's not. That's kind of old-fashioned rejection where, before we had the powerful medications we have now. Unfortunately, we don't have good symptoms that we rely on to help us with rejection. That's why we do blood work so often. There are studies right now looking at urine markers to try to figure out if there's ways to screen people's urine to get an early tip on rejection. But obviously, have pain over the graft, you need to contact pain over top of the transplant kidney, you need to contact your team. But that's we don't see that often anymore. So that's a very long way of saying there are not many symptoms that we can rely on for rejection.
And does that also pertain to the donor if their lasting remaining native kidney, same concept, like if it's going into rejection maybe?
Donors won't reject because the donor, the remaining kidney in the donor they were born with it. So their immune system recognizes that kidney as a part of them, and the immune system is happy with it. It's only in the recipient where the immune system sees something and treats it like an infection because it treats it like it doesn't belong to them. Yeah.
Good to know.
Yeah.
What is the life of an E-block transplant? And is it true that kidneys... Good.
And an unblock?
Possibly en block.
So en bloc is when for some reason some deceased donors will not have enough kidney function to split the kidneys, to have one kidney go to one person and one go to the other. So sometimes both kidneys are put in a single recipient. And some surgeons will do one on one side, one on the other side. And some surgeons prefer to do it en bloc, which just means that the 2 kidneys remain attached to the donor blood vessel, and they just sew them in together. So you'd have two kidneys on one side. Off the top of my head, I don't think there's any difference in the survival rate for en bloc transplants.
And then do they grow with age as well?
Oh, maybe we're talking about a pediatric en bloc. Yes,
Clarify.
okay. So because the blood vessels are so small for a pediatric deceased donor, they will often transplant them en bloc so that they're together. It makes the surgical connections a bit easier. They're still very hard, but a little bit easier. So those, and yes, pediatric kidneys grow quite rapidly, actually.
Back to a bit of a donor perspective, can donors' own health history or complications transfer to the recipient?
That's a really interesting question. For the most part, no. There have been, so if we were taking donors who are unscreened, and yes, there's lots of infections that can transfer from donor to recipient, but we go to if for both the deceased donors and living donors, we screen them extensively to make sure that doesn't happen. And in some cases, when we do transmit hepatitis C, we know it and then we treat it afterwards. In terms of other like non-infectious things that can transfer, there have been cases of malignancies transferring. And interestingly, there apparently are some case reports of allergies being transmitted from donor to recipient, specifically a peanut allergy. So that's something that we have our allergy team assess if that type of relationship happens between a donor and recipient here.
Okay, awesome. Just gonna jump back to the Q&A area. For someone diagnosed with IgA, what is the possibility of IgA coming back? And what are the warning signs for that as well? And what are the treatment options for slow progression?
So the risk for IgA is very high that it'll come back, and it depends how hard you look for it. Often we'll pick it up on a kidney biopsy that we're doing, and we see IgA staining on the kidney biopsy, and it can be of no consequence for a long time. As I think I said before, the disease course tends to follow the way it happened the first time. So some people with IgA will have IgA for a decade before they have any kidney problems that result in dialysis. Other people will progress to dialysis very quickly. That the same thing, you could expect a similar course to the original disease. But that's broadly speaking. I would say in general, the IgA moves a bit slower because of the added immune suppression that we're using. So, when you had IgA the first time around, you might have been on some prednisone, but nothing else. With the transplant, you're on prednisone, the antimetabolite, and the tacrolimus, and that seems to slow things down a little bit. The treatment for IgA that reoccurs after transplant is a controversial area. Some people treat it the same way as you do before transplant. Other people don't feel that further treatment with prednisone is warranted in the post-transplant setting, and then they would just monitor and try to keep the blood pressure and the protein in the urine well controlled. The warning signs that I think is most effective is to monitor the urine protein levels. So for IgA patients, after a transplant, it's important to get a baseline protein level because then the original kidneys are probably still peeing out some protein. So it's good to get a baseline, and it's good to get protein levels done regularly to see if there's been a substantial change in that or not.
Great. I guess there's a lot of infections going on, and a lot of people having issues with other viruses and whatnot. So we have quite a few questions related to that topic.
Okay.
So one is about CMV and the BK virus for post-transplant recipients. So you can talk a little bit about that.
Yeah, it's good to talk about them together because they're similar virus. So CMV is in like the family of viruses like chickenpox. So just like chicken, you know how you can get you get chickenpox when you're little, and then you get shingles reactivate when you're older. That's because those viruses don't get cleared from your body completely. Your immune system just holds them at bay for your whole life until something disrupts their ability to do that. So some people will get a shingles attack, if they're sick or really stressed out. And similarly with CMV, your body holds it at bay until we give you immune suppressing medications, and then the CMV levels can present themselves again. CMV, like when you're a little kid, you probably caught it. About 85% of the population, 70 to 85% of the population has CMV, and it just gets reactivated after a transplant. I'll just stick with CMV. So CMV is a bit more of a dangerous virus than BK. It's not terribly dangerous, but it can cause problems if it gets into the bowel. If it gets into the lungs, it can be very bad. Usually we pick it up before that happens, and it's got a treatment. So we treat people with a drug called valganciclovir. And there's an intravenous version as well that can be used if people can't tolerate the oral version, like if they have really bad involvement of their stomach and their bowels. The vast majority of people with CMV in their blood, it gets better when we cut back on the immune suppression a little bit, and sometimes people need the oral medication. It's been a very long time since I've seen the most dangerous version, which is the CMV lung disease. We do see some bowel infections regularly. Once again, they respond to reduction in immune suppression and also the medications. BK is similar. It's not in the same family as CMV, which by the way stands for cytomegalovirus. BK doesn't really stand for anything. BK is named after the first patient in whom it was discovered, which is kind of a dumb way to name a virus. So it stands for that person's initials, which doesn't help us scientifically at all. But so that's why it's called BK virus. It's got a relative named JC virus, which was named in a similar way. It's usually not an issue for people who have been transplanted. So BK virus is not in the same family as CMV, but it does kind of the same thing. It's a virus that you pick up when you're a kid. Your immune system keeps it under control until something happens with your immune system, like getting on immune suppressing medications. So BK is not like CMV. CMV will run around your whole body and can cause problems with bowels and lungs and other areas. BK is usually just restricted to the urinary tract. So it can cause problems with obstructing the urine outflow from the kidney. It can also infect the new kidney directly and cause damage. Unfortunately, BK has no treatment that's specifically targeted to it. So what we do is we usually change the immune suppression medications and lower the dose a little bit, and that allows your immune system to deal with the virus. For people listening to that who are wondering about rejection, yeah, you're right, that is the big problem. The biggest challenge in transplant medicine is balancing infection risk and cancer risk on one side with rejection risk on the other side. How to balance the medication, how to balance those risks is different for different people, and it's part of the art of this process, and it's probably the most challenging part of the process.
Okay. We're gonna kind of switch it from adults to peds.
With the understanding that I am not a pediatric nephrologist, but I'll give it a shot.
Yes, exactly. With a young child at home, I am more at risk of getting sick due to the bugs that they bring home from school.
I know that.
With that, will that affect the longevity of a new kidney? So actually, sorry, this is a parent who's transplanted.
Oh yeah, no.
My bad, sorry.
Yes. Yeah, so our transplant patients who have young kids and who are school teachers get more upper respiratory tract infections, and they take longer to resolve. It's not impossible, but I don't see a lot of really serious outcomes from those infections. That having been said, some of them can be serious. So I think, as I said before, it's better there's only so much you can do. You can't cloister yourself away from your children. You can help them with like proper hand hygiene, both at home and at school, and covering their mouth when they cough, things like that. It could be a teachable moment for your kids from a personal perspective. As a patient, the only thing I think you can do is just be a little bit cautious about waiting too long to get help. Usually, if you have a high fever and you're a transplant patient, you need to contact the transplant team. You need blood tests, you need a chest x-ray, depending on the symptoms. But whereas people who are not immune suppressed can often just ride that type of thing out at home, I think if you're feeling unwell and you have a fever, you're concerned about your health, if you're immune suppressed, it makes sense to get attention earlier rather than later.
Now, this is going back to the THC. So
my video is up. If my video wasn't up, I would be Googling this in the background and sounding smarter, but
you could totally stop sharing if you want, by the way.
no, it's fine.
Okay. So it's an interesting question. So you mentioned THC. What about alcohol in moderation?
Alcohol in moderation should not be a barrier with transplant. Obviously, alcohol in excess has got its own health consequences, and if you drink too much, you tend to forget to take your medications. So those are the challenges there. So we don't recommend people drink, but it's not a barrier.
Now, let's see if you know this one. Are there any concerns regarding patients getting massages and facials with the use of massage oils and creams?
Not that I know, not that I've heard of.
You.
No, that's something that's like that. Things like that, they're not part of my practice. So it's not like I see, 4 people a week who ask me about massages. I've never been asked that before. So I was just thinking back whether in my career have heard of any complications arising from massages or oils, and I haven't. I haven't searched literature, and the literature is often rife with weird stuff. I think a few years ago, if you'd asked me if you could get a peanut allergy from getting a transplant from someone with a peanut allergy, I would have been a bit stumped as well. But now I know that that's something that can happen. It's just super rare. So I don't think there should be any barrier to massages or the use of oils in the massage. It might be uncomfortable to have the kidney massaged, but your face and your back is probably good.
Yeah, as long as you let them know you had a transplant, to be cautious of this area. If it's a body massage, then otherwise you should be okay. Okay.
I think so.
Medications and weight gain. That's 2 people have asked that question.
Oh, like Ozempic?
Probably from the prednisone.
Well, I mean, there's not a lot to say about it. Yes, it happens a lot, and I'm always torn about it because gaining weight is, there are health consequences to gaining too much weight, but also I like to see that people are feeling better after transplant. So I don't tend to jump on people about it until it's causing problems with sugar control and blood pressure. But it's a common problem, and I think prednisone gets a lot of the blame for it. But I think people lose track of how rough dialysis is because patients are tough and they get used to it. I think a lot of people have a substantially reduced appetite when they're on dialysis, and that gets improved with both the prednisone and the transplant. So it's common. The medications do contribute, we do our best.
Okay. So going back to the question about alcohol for recipients, is it the same for donors, for living donors? Any different than for them in consumption?
No, there aren't a lot of restrictions for donors. One interesting thing is I don't do any work with kidney donors, and that's on purpose. We keep our donor and our recipient team separate because there's a conflict of interest. If I have patients who need a kidney, I'm in a bit of a conflict if I'm recommending people to donate, because my concern is with my patients. So I might not make wise decisions for donors because I've my interest in the recipients. So because of that, we keep the program separate. But besides like trauma to the kidney, there are not a lot of restrictions placed on donors. Like your kickboxing career is probably over, but otherwise there are not a lot of restrictions on the donor.
So maybe next time we have you, we can have you and one of the transplant donor coordinators join us, so you guys can tag team together.
Yeah, Amit Garg does a lot of work both from the research and the clinical end on donors, and it'd probably be hard to find someone more knowledgeable than him, like even in North America. So he'd be a good one. I just threw him under the bus, but yeah, he would be a good one to talk to if people have donor specific questions.
We've had him join before, so that'd be.
Oh yeah, get him again.
All right, let's see. You have a comment that would be amazing if we did something like that. So there you go.
Okay.
You're already booked for our second one, so
okay.
The people have spoken.
Good.
All right. Another question. I think we have 2 or 3 more questions, and then we'll kind of wrap it up. But does the fear of new kidneys getting rejected ever go away?
This is something I talked to Riz about. I'm not a patient. I'm always scared of it, but I'm not a patient, so I don't. People deal with risk in different ways. I certainly have patients who are too worried about rejection, and I have other patients who are not nearly worried enough. I would say most people are kind of neutral. I think it's always in the back. This is why doing home blood pressures are really important for transplant recipients, because when people come to clinic, I think they're always worried that their creatinine's going to be up, and we're going to tell them that they might have rejection and they need a biopsy. And as a result, their blood pressures in our transplant clinic are always inaccurate. So I don't know. I doubt that fear is ever totally gone. I think people just have different ways of dealing with it.
And what are some of the things that folks can do, even when they do blood work, to make sure that when they do go in for clinic, blood work is good, but they can do in terms of keeping everything as stable as possible?
I think the routine, like the more regimented you can be about your medications, the better. And as I don't know if I explained it well before, but when we measure the levels of the transplant drugs, which allow us to change the dosing to hit the right targets, we rely on the level that's done right before you take your next dose. So people come to transplant clinic, we tell them don't take your tacrolimus until your blood work's drawn, and then take it right afterwards. And that is because we're hoping to get the absolute lowest level in that 24 hours tested on that patient, because that's how we do our levels. That's how everyone does their levels. So if you get your blood work drawn at 8 a.m. before transplant clinic, but you're in the habit of taking your pill at noon, then that level that you get at 8 a.m. the next day isn't going to be your lowest dose. It's going to be artificially high. And so we might either lower your dose, or we might think, oh, that's adequate, when in fact you're not on enough of the medication. And vice versa. If you normally take your pill at 6 a.m. And you get your blood tested at clinic at 8 a.m., then the test that we get is going to read artificially low. And so that we might increase your medication and put you more at risk for infection. So it's easier said than done. And I'm not saying this is just everyone should just do this with a snap of a finger. But if people are wondering about things they can do to reduce the risk of infection, helping us get reliable drug levels is important.
Yep, very good. And in this part, I would like to plug that we do have our transplant and living donor support group. So if you have questions from amongst your peers, because peer-to-peer support is really important to know what's going on and what's happening, that's a really good group to join, just FYI. Another question is, any specific recommendations on vaccines?
So we recommend, I mean, vaccines is a hot topic, but we recommend all vaccines before transplant. The problem with transplant is the medications blunt your immune system's response. And so we are trying to blunt your immune system's response to the kidney, which is foreign material that's in your body. And that's what a vaccine is too. It's foreign material in your body. So the medications that we use blunt your response to vaccines. So we try to get all the vaccines done before transplant because we know the ones we give you during transplant are a little less effective. But that doesn't mean they're completely ineffective. We still recommend regular flu shots, COVID shots. We recommend the Shingrix shingle shots as well. The only vaccines we don't recommend, or we tell people not to get, are live viruses, because live viruses can reactivate in people who are immune suppressed. So things like when people are traveling, like yellow fever is a live virus. The measles, mumps, rubella is a live virus as well. So we make sure people have those done beforehand if they need them.
Awesome. Okay. Next we have a question on myfortic.
Yep.
What is the time range if you miss in terms of not taking your outer graft or myfortic, and within 1 to 2 hours, can you still take them? So what's the time frame?
Yeah, one to two. I don't know what at a certain point, if you normally take your pills in the morning and you're going to bed and you realize you forgot them, it's not harmful to take them. It does mess things. If you're planning on going to clinic the next day, it's going to mess up your levels. And I think if that happens, you just need to tell the people at clinic, hey, I missed my pill last night and I took it late. My levels are messed up. But doing things like doubling doses and things that aren't needed, I would just take them as soon as you remember.
And I really liked what you said about the water, about the 3 liters and not going too crazy on that also, because I know a lot of patients get paranoid when their levels are off and they feel that they have to drink more in order for things to level out. So
that's I don't want to I don't want to be too controversial, but I don't like it when patients get blamed for their bumps in creatinine. If you're having rejection and you didn't take your pills, then that's something that the patient needs to own. If you're having rejection and you're taking your pills at least somewhat regularly, and your creatinine bumps up, if someone says, "Well, how much water you're drinking?" and you say 2 liters, and they say, "Well, you need to drink 3 liters," I don't like that. That's laying the blame at the feet of the patient for something that's just random sometimes. And there's no proven benefit. I mean, if water fixed rejection or water fixed creatinine, we would use it all the time, and it doesn't. So we don't, and it's a throwaway statement that some doctors make, but it's a daily challenge for people who are trying to drink 3 liters of water a day. It's hard. I don't drink 3 liters of water a day.
You're getting a lot of hearts and thumbs up, because I think that's really refreshing to hear from a nephrologist that it's not always the patient's fault. And that's really awesome.
Yeah, I think part of it comes from not wanting to say I don't know. Nobody gets into medicine to see a patient with a creatinine that's doubled and say, well, I don't know what's going on. But it's true sometimes. We just don't know until we do a biopsy and figure things out. So it's not that anyone's being lazy, but I sometimes just think that some people don't think of what the patient goes through when you say, well, you just need to drink more water.
Yeah. And that's been said more often than we would like to hear at times. So Yeah.
Yes.
All right.
There's few of my partners here who are on my team. There's people on the other team though, so I don't want please don't take my
Every,
name if you are if
just
you're
like you
going to get into an
mentioned,
argument with your nephrologist.
no, every patient is different. Every
Yeah,
nephrologist, doctors are different. It's all about working as a team and providing the right information to each other, especially as patients.
yeah,
Um, being open and honest with your team so that they can give you the right care. It's only going to benefit you at the end of the day. So
yep,
that's really important.
yep.
Okay, let's see what's some last few questions. All right. Um, so one person said that their GP, and a lot of GPs don't know much, or they know a lot about transplant, but not the nitty gritty sometimes, even with kidney disease.
Mhm.
They recommended the B12 injection to one transplant recipient. So what are
No,
your thoughts
that
on that?
beats what I mean. So first, a comment on family doctors. I don't know if there's a harder job in medicine than family medicine. And so they don't know about transplant, and they shouldn't know about transplant because they've got enough other stuff to do. So family doctors are burdened as it is. So I don't expect them to know anything. They do tend to kick a lot of stuff back to us. Partly, I think, because they're scared to mess something up, which is totally reasonable. So yeah, family doctors don't know that much about transplant, and that's okay. The B12 shot, B12 is just a vitamin. Some people don't absorb it very well from their stomach. It can cause some problems with your blood counts. I mean, it's probably as harmless as it comes. So it might not be necessary, but it's definitely not going to be a problem.
All right, and we're gonna one more question. And just for everyone's knowledge, this is being recorded. So if you missed something from Dr. Weir's presentation, you can always rewatch it. So no stress. This is actually a good one. If your donor kidney rejects, do you start at the bottom of the deceased donor list?
Um, the the algorithm that Trillium and Gift of Life uses is complicated. Uh, to say you start at the bottom is probably not totally accurate. Um, there's a lot that goes into determining your ranking on TGLN's list. Um, People who are preemptive, which means they're not even on dialysis, but they just have a low level of kidney function, they tend to be lower than people who are already on dialysis. Um, Usually, by the time you go through the workup to get another kidney transplant, you've been on dialysis for at least 6 to 12 months. So you've already accrued some more waiting time. So to say you go back to the bottom of the list is probably not accurate. Similarly, people who people who need two organs, like people who might need a liver kidney or a kidney pancreas, combined organs rank higher than single organs. So somebody could fail their transplant and then end up higher on the list afterwards if there's some special consideration. People who are very sensitized, which means their immune systems have seen a lot of other people's immune information, either through transplants or blood transfusions or pregnancies. There's a special waiting list for highly sensitized people, and that's a national waiting list. So it's a very complicated process. So to say you do go back down, obviously, because they don't just keep transplanting the same people, but to say you go back to the bottom is not accurate. It's a whole complicated calculation.
Okay. Well, I thank you so much. Those are our questions. I'm going to pass it on to Riz now to kind of end us off. Rizwana.
Thank you. All right, I'm going to share my screen very quickly.
I'll stop sharing. There we go.
Thank you. So, Dr. Weir, thank you so much for today's presentation. I'm sure that every participant that has joined us today will leave feeling a little better now that their questions have been answered, and we are already looking forward to having you back. I will be in touch.
Yes, for sure. I think the question and answer format works pretty well. That way people have to listen to me drone on about things that are only important to me, and I get to the questions that people care about.
Wonderful. Thank you.
Great. All right. See you later.
Thank you.
No problem. Bye.
So I just have a few quick announcements to make, if I can get my screen up and running. As you all know, April is National Organ and Tissue Donor Awareness Month. And Sunday, April 7th, you may have already heard, is the Green Shirt Day. So we encourage you all to wear your green in honor of Logan